The actual skin cancer, cutaneous squamous cell carcinoma, as opposed to squamous cell carcinoma that arises on mucosal surfaces in the body. Very different risk factors, different prognoses. The entity we're talking about today is squamous cell carcinoma of the skin. I mentioned already about those arsenicals and tar compounds. There we are. There are certain familial syndromes. One has to do with defective DNA repair. You've already heard about that. I think in general pathology, xeroderma pigmentosum, higher risk of both squamous carcinoma of the skin as well as basal cell carcinoma we'll be going into. Chronic immunosuppression, which is people that have organ transplants or on chronic immunosuppression, they are at a much higher risk of cutaneous squamous carcinoma. Look at some of those figures there as far as how much of a greater risk they are of different cancers and how much worse the cancer is when they get it. It behaves badly in these people. So carcinoma in situ. I've been talking to you about clinical entities so far, but carcinoma in situ is a microscopic diagnosis. I'm only mentioning it here so you're clear on what it is, because it can correlate in some instances with certain clinical entities turn out to be CIS microscopically, but it's a microscopic thing. So it's when you have all the changes of cancer cytologically, but they are above the basement membrane and haven't broken through the basement membrane is intact. So all those features of hyperchromasia and varying sizes and shapes of the nuclei and of the individual cells, increased mitotic rate, and dyskeratosis, individual cell keratinization, as well as architecturally in the form of, here you see these teardrop-shaped, bulbous, bulging reedy ridges. That's an architectural indication of CIS, architectural change. When we see CIS in the mouth, we can't tell it's CIS. We can't tell if it's a mild dysplasia, an invasive carcinoma, or a CIS. But there are types of CIS elsewhere in the body that have the names you're seeing here, Bowen's disease and erythroplasia of K-rod. And they tend to be, once they're recognized for where they are, where they occur, to be CIS. So erythroplasia of K-rod is when you have these well-defined red areas on the genitals. Bowen disease is a term used by dermatologists for CIS in other parts of the body. Just know the term Bowen disease is CIS. And that's it for CIS. So now let's talk about the clinical entity of invasive squamous carcinoma. So this is the second most common cancer arising in sun exposed skin. Melanoma is relatively rare. The most common one we'll go over in a minute, which is basal cell carcinoma. Well, there was one thing I wanted to show you as far as these lesions. So when you notice they're both very well defined, where the red is and isn't, where the red begins and the normal skin is. So CIS lesions tend to be very well defined, where they begin and end. Unlike, when you see red lesions, and you're going to learn this, you will hear me say this 100 times in oral pathology. When you see something red in the mouth, think trauma first, because it's going to be 100 times more likely than any kind of a dysplasia or cancer. So even here on the skin, I'm sure dermatologists often think of trauma first. One indication that it isn't trauma is this sharpness of the edges. Okay. Normally, you have squamous cell carcinoma beginning in a premalignant lesion. such as one of the ones you've just heard about. Fortunately, the lesions due to sun exposure aren't all that aggressive. I mean, in an immunocompromised person it would be, and one of the tumors evolving just because of chronic immunosuppression would be, but the run-of-the-mill squamous carcinoma of the skin fortunately grows quite slowly and is very curable. It can have a variety of appearances. All of these are quite advanced, but they tend to be scaly, which means hyperkeratotic microscopically, or rough in texture. They can be the same color as the surrounding skin. They can be yellowish, they can be ulcerated or not ulcerated, very much a varying appearance. Common to all of them is that they will feel very hard. They are indurated. So if you see a lesion that doesn't look like much, this includes in the mouth, and it's indurated, like more so than you would imagine by something that looks so relatively inconspicuous, that's not a good sign. Because epithelial and mucosal cancers often induce a fibrous response in the underlying connective tissue, and that's what it's due to. And this elevated margin, you'll see a little bit later, is typical. A ledge-like appearance to the margin is a bad sign. You should be able to recognize microscopically the difference between carcinoma in situ and invasive cancer because of the irregular, sharp, kind of like tongue-like intrusions of the malignant cells on the left, and those swollen bulbous ridges filled with malignant cells on the right. So that's invasive cancer versus CIS. Squamous carcinomas are frequently graded based on how much they resemble normal, the maturation of normal epithelium. So well differentiated, I wish you could see the whole epidermis there, but realize that you have a lot of keratinization going on. You can see individual cell keratinization. You can probably see there under higher power intercellular bridges. That would be typical of a well-differentiated lesion. And you get to the other end, poorly differentiated. You can't even tell necessarily that it's a skin cancer. You can just tell that there are sheets of malignant cells, moderately would be in between. You have some, it looks like keratin pearls there as well. And then very undifferentiated can be in different forms. And one of the forms is spindle cell, meaning it doesn't even look like cancer. It looks like a sarcoma. Sarcomas, soft tissue malignancies, often have a spindle cell form. Again, cytokeratin immunohistochemical stains would show you that you're dealing with epithelial cells. So as far as pathogenesis, the genetics point to, all cases, basically a P53 mutation is one of the earliest events, and then dysfunction of other apoptotic regulatory proteins. It's been fairly well elucidated. If it interests you, your textbook has a lot more information on that. Oh, before we go into this, let's go to the prognostic factors. Things that make a squamous carcinoma likely to behave worse. If it's bigger, deeper, if it's already gone deep into some of those structures you see there, if it has a high grade, notice that the grading is not the most important thing in prognosticating for squamous carcinoma. It has some influence, but it's not nearly as important as some of the things I just mentioned, or very important, whether it's spread to adjacent nodes or elsewhere. Certain locations are at a higher risk for a more dangerous tumor, and some of the other factors you see there. How are they treated? It all depends on where they're located, how small they are. I'll show you an example of this Mohs micrographic surgery, which is kind of the best type of surgery if anyone you know has been diagnosed with a skin cancer on an aesthetically sensitive portion of the body, particularly the face. It tends to be now the treatment of choice. Radiation for inaccessible lesions, large lesions, etc. Now let's talk about basal cell carcinoma. You already know that this is the most common skin cancer. It's the most common skin cancer in the US and worldwide, 1 million cases per year in the US. They're slow growing, thank goodness, and they are definitely related to sun exposure as well. Fair-skinned individuals, yes. Older individuals, yes. And slightly more common in men than women. Also, same thing, xeroderma, immunosuppression. One thing a little bit different is this nevoid basal cell carcinoma syndrome that you'll learn all about neuropathology because it's associated with certain oral manifestations, but you'll learn more about that. And that's only basal cells that's associated with that. Most common site, the face and scalp. So will you be picking these up early? Sure, because you'll see them. Here's an early one. Where is it? Well, you can see the texture of the skin is different. It's slightly raised. It has a kind of a pearly or waxy appearance. The pores of the skin, the pores are missing, so it has a uniform kind of a shininess to it. It's a very early basal cell in a typical location on the face. At the area of the nose is a common location. The ears, common, okay? Here are some more advanced lesions. They have some of the characteristics, common characteristics of basal cells when they're more advanced. They ulcerate. They can develop into a nodule. And you can see, actually, if you look carefully on all three of those pictures, they have these proliferation of small vessels, telangiectasias. Okay. More advanced lesions. Now, these don't tend to metastasize. Basal cell carcinoma is very rare, very rare. But you leave them untended, and they just keep eroding away, going deeper and going more laterally. And if they appear on the face, on the scalp, maybe not as bad, but if they appear on the face there, you start to get into areas that are very difficult to treat aesthetically once they get past a certain size. There's that rolled border that you also get in malignancies of squamous carcinomas. For some reason, these were called rodent ulcers in the past, and the rodent doesn't have to do with a mouse eating anything, and I can't remember what it has to do with, but rodent ulcer is the ancient term for this particular entity. Typical microscopic appearance, blue-purple. You see all that? Because it's all solid nuclei with no cytoplasm. So that's what a basaloid cell is. When you say you have a basaloid proliferation, it means resembling basal cells, which, as you remember, have very little cytoplasm, normal basal cells in the epidermis. They're all packed nuclei right next to each other. And so a basaloid proliferation would look like this. Nests of basal cells, and palisading is when you have the peripheral cells of the nest arranged like little soldiers, all lined up. That's palisading. And that would be a term you'll hear associated with other odontogenic neoplasms. Just scanning my notes to make sure I'm not missing anything here. So Houston, we have a problem here. We have a very aesthetically sensitive area where anything, I mean, as if this wasn't noticeable enough already, but any treatment that's done in this area is going to be very difficult to achieve good aesthetics. Best bet is if you can remove as little tissue as possible. And that is where Mohs micrographic surgery comes in. It is not paid for by all insurance plans. It tends to be expensive because not only is there operating room and surgery and surgical staff time, there is a pathologist that has to be present for the entire procedure, ready to receive frozen little pieces of this of the resection, one piece at a time, and then look at it, as I think I mentioned the other day, put under frozen and then sliced off, looked at multiple times over a period. Sometimes it takes a couple of hours or longer to remove all the cancer with removing as little normal skin as possible. Kaposi sarcoma. This is a tumor of endothelial origin, not of the skin or the skin appendages. I'm not going to mention any of there are a variety of obscure tumors that are due to what are called adnexal structures or skin appendages. Those two terms are synonymous, skin appendages and adnexa or adnexal structures. So there are tumors of just sweat glands, of just sebaceous glands, et cetera, all obscure. You don't have to know them, just to let you know they exist though. And this is a tumor of endothelial origin. But it's clearly visible on the skin and it manifests itself on the skin. Not that it doesn't in advanced cases manifest itself deeper in internal organs, it does. But it frequently starts in the skin, so it's being presented here as a skin tumor. So it is a multifocal lesion, cancer, a multifocal malignancy of endothelial origin, directly related to an infectious cause, HHV8, also otherwise known as KS, Kaposi sarcoma virus. It occurs in these 4 clinical variants. One that most clinicians in this country and most of the public in general are aware of are the age-related Kaposi sarcoma, but in other parts of the world, there are different types of Kaposi and they behave differently. So the classic one, before AIDS even came into the picture in the 1970s, was the one that occurred on the legs of men of Mediterranean, in the origin of Mediterranean countries like Greece and Italy, Turkey. And it was a multifocal tumor of the vessels of the skin. And it progressed very slowly, and that was the only Kaposi really that anyone would occasionally tend to see in this country before AIDS. There's always existed this endemic African Kaposi, which is, like in Uganda, it's the second most common type of cancer. In certain communities, very, very common. And it tends to be rapidly progressive, often involves the lympho-reticular system, spreading to lymph nodes, different parts of the body. But we don't see that here. And then there is a type of Kaposi associated with immunosuppressive therapy, which is slightly different from the AIDS-related KS. What do you need to know? You need to know how to recognize early Kaposis in what you will perhaps identify based on clinical history or other things as a high-risk individual. There are the early lesions on the left. I know you've already had presentations about AIDS and HIV, and you've seen examples of Kaposi sarcoma. Here are some other examples for you. Start out as flat lesions, and slightly raised plaques, reddish blue. They can merge, coalesce these lesions, and then they become raised and nodular. And they can regress, and new ones form as the old ones regress. microscopically, you should be able to recognize that these are spindle cells with a lot of blood. So you see spindle cells with these slit-like spaces of erythrocytes jamming these hard-to-see slit-like spaces, and that is a very typical appearance of kappa C sarcoma. And nowadays, immunostain for HHV8 is done, lights up brown color, uniformly all those cells, and you have your diagnosis. Individual kappa C lesions are very responsive to certain types of chemotherapeutic drugs injected directly into the lesions, for example. So inflammatory dermatoses. Okay, so we're dealing with inflammation, inflammatory conditions of the skin. Let's talk about two categories. We're going to talk about two diseases only today, urticaria, hives, and psoriasis. So we have hives as a good example of an acute inflammatory dermatosis. These last from maybe a day, maybe a week or so. They have inflammatory infiltrates going on in the lesions and usually some degree of edema. Chronic dermatoses go on for months or years, and the skin changes there are long-term skin changes like of hyperkeratosis, thickening, fibrosis underneath. That's what you see in the chronic dermatoses. All right, urticaria. Very common lesion due to localized mast cell degranulation. So you have the mast cell degranulation occurring, I'll tell you why in a minute, and you have dermal then microvascular permeability, and these lesions, which are called wheals, W-H-E-A-L-S, and they are intensely itchy, intensely itchy. Here's another example. All age groups are susceptible, but it's a little more likely to be in young adults and early middle-aged individuals. Itching is the first sign of hives even before the lesions appear, intense itching. Pruritus, right? These lesions may last, individual lesions always last less than 24 hours, but another crop of lesions might show up again in another day or two or three, and then everything tends to resolve. It can be brought on, it's brought on basically by antigen-induced release of vasoactive mediators from mast cell granules. After these mast cells undergo sensitization with specific IgE antibodies. Pollens, foods, drugs, an insect sting, a variety of things can bring on hives. Certainly food allergies. My sister gets a breakout from ibuprofen. She has to take Tylenol, and it's the only thing she gets hives from. And, so have any of you ever had hives? They're very, very common. They're not associated with anything bad. A few of you, yeah. So how do you treat? Did you treat yourself, or did you go in the hive? How did you treat yourself for hives? Remember?
Salty hot shower, gets rid of the itchiness.
Yeah, right, because it degranulates the mast cells, and yeah, that works for a lot of processes that involve mast cells. Hot shower. Even though another technique is to put cool compresses on, but it doesn't work as well as that hot shower thing does as far as relieving. What else? Right, antihistamines are usually what people are told to do. All right, here's a summary slide for you. This is a chronic inflammatory dermatosis. This isn't This is not so nice to have. It's very common. Maybe 1 out of 50 people have some psoriasis. It's not like hives, it's not going to go away quickly, it's a chronic condition. It appears to have an autoimmune basis. The exact inciting antigens really are unknown. Like 1 out of 7 or 8 people with psoriasis will have arthritis. And the hands are a common place, but the arthritis can be anywhere. And it can be similar to rheumatoid arthritis, another autoimmune process, right? Nails are frequently affected. Let's go back here for a moment to take a look at what the lesions look like. Well-demarcated plaques. They start out as reddish or salmon colored, and then they get covered with a silvery scale, which is what you're seeing here. The scale flakes off easily. Changes in the nail bed occur in some people. Arthritis, fortunately, in not that many, but it's relatively common. In oral pathology, we mention psoriasis because microscopically it resembles a very common condition called geographic tongue, microscopically. So in this case, you think, oh, they're the bulbous reedy ridges of CIS. Well, they are in a way, but they're a little thinner. We call them test tube reedy ridges. They're not filled with dysplastic cells. They're filled with normal epithelium, but that appearance of the test tube reedy ridges is typical of both geographic tongue and psoriasis. But then on the right, I don't know if you can see this sort of dusty little multi-lobe nuclei on the surface. Those are neutrophils, or neutrophils that are in the process of dying, and they percolate up and they stay in little nests way up towards the surface, and those are called Monroe microabscesses, typical of both of those two processes. Finally, notice, going back to the left-hand slide, that in between the reedy ridges, you have the dermal papillae, and that the tips of those dermal papillae frequently, there's an example of one of them, reach quite close to the surface. And that results in a phenomenon called the Auspitz sign, which is when you remove one of those scaly plaques. Here you just see a drop of blood, not a very good image. But when you first remove the plaque, you see tiny little pinpoint areas of blood, which are the tip of those dermal papillae that are starting to bleed. Fortunately, most outbreaks of psoriasis aren't too extensive, and they respond fairly well to a number of treatments. Topical steroids, a class of drugs called coal tars. Phototherapy is often used, of specific exposure to certain wavelengths of light that helps. So these topics here, it's always tricky to figure out which skin lesions or mucosal lesions I will, put out in oral pathology and which in systemic pathology too. These we're going to cover in oral path. Erythema multiforme is a bit like hives. It's an acute dermatosis. Lichen planus is a chronic one. And then pemphigus and pemphigoid are vesicular bullous that we didn't talk about at all today. So that's it. Are there any questions?